Hello, everyone. Hi. Are you hearing me well?
Yes, perfectly.
Okay. So I'd like to welcome you all, and it's my pleasure to be with you today live on this webinar from Bob Dentistry website. Actually, today we're going to speak about a very important topic, which is root canal shaping and how to avoid errors that could happen during root canal instrumentation. So everything is going fine before starting the lecture?
Yeah, you can start.
Okay. So today I will describe to you how to safely shape root canal and how to reach to the apex and avoid many errors that could happen, like instrument separation, ledge, perforations. But no one can deny that all of us are happy by these shapes when you end your obturation or your treatment and you find you were able to maintain the curvature, you reach safely to the apex, you have 3D filling. I think all of us will be happy when we see cases like this, but we should not ignore the biological objective of the treatment. Actually, shaping itself is not an aim for treatment. We should consider the biological objective in the first situation. Shaping process is to allow sufficient irrigant to reach to the apex, reach to areas that were not able to be touched by mechanical instrumentation. And all we know that root canal system is so complex. It is not that shape we are doing by our files. No, we have anastomosis, we have lateral canals, and the complexity of root canal system needs to do instrumentation to the canal to allow us to reach by our irrigant for these areas, to clean and to disinfect these areas from microorganisms that may be responsible in future for biological failure. So the mechanical objectives of our treatment is to allow sufficient irrigation reach to the apex. Actually, this is while shaping the canal, we need to prepare the canal to allow sufficient irrigation reaching to the apex, also to allow easy obturation and 3D filling to root canal system. Nowadays, in the era of minimally invasive, where we can see less tapered preparation, less flared preparation, we might find some difficulties in obturating this kind of canals using warm vertical or warm gutta-perca obturation technique. You try to insert your plugger, your heat carrier, you might find difficulties to obturate the canal well by warm 3D obturation techniques. That's why we might consider the obturation using bioceramics maybe a solution in cases like this. While preparing the canal or shaping the canal, we need to maintain the side integrity of the apical foramen. We don't want to destruct the apical foramen structure. Also, we need to preserve as much as sound dentine structure for long mechanical success. We all saw many cases with large preparation, large tapered preparation, maybe over-prepared. And we can see weakness of remaining structure of dentine and root. And these cases already had a mechanical failure or mechanical fracture. Vertical root fracture also might happen in these cases. That's why we should consider the preservation also of sound tooth structure during our treatment. The steps of biomechanical preparation, or the correct term for cleaning and shaping, which is shaping for cleaning, starting from pre-flaring, glide path preparation, ending by apical finishing. During these steps, we need to maintain irrigant and disinfectant in the canal to disinfect the root canal system, also as a lubricant for our mechanically working files. This is the aim of canal shaping, is to transfer the canal from this shape, or the green one, into this red shape, the continuous tapering. while doing this step, we need to maintain the site of the apical foramen. Starting by the first step in preparation, which is a mechanical pre-flaring. Actually, mechanical pre-flaring is to prepare or enlarge the coronal 1/3 of the canal, removing any coronal obstruction. According to literature and clinical practice, this will reduce the incidence of ledge formation, instrument separation, canal straightening, or even apical perforation. This is the way we are doing the pre-flaring. Many times, or most of times, we can use orifice opener or orifice shaper, whatever they call according to manufacturers. Sometimes also in the past we used Gates Glidden in crown down sequence, size 3, size 2, size 1. I just want from each instrument 1 millimeter inside the canal. So at the end, I will be having a flared 3 millimeter in the canal, which is enough for coronal pre-flaring. Most of these files which are used for coronal enlargement are short files, small tip diameter with larger taper, because we need this instrument to work only in the coronal portion of the canal to enlarge it. So for safe pre-flaring step, we need to insert without any force or any pressure, just K file size 10 passively. No pressure, just insert the file, no watch wind motion, no any motion. Try to insert. If the file goes 3 to 4 millimeter, 5 millimeters, this means this length is safe to use the mechanical files or the pre-flaring files, pre-flaring rotary files to prepare the coronal 1/3. If the file is not going easy to deep in the canal, that might represent a challenge to you if you want directly using a pre-flaring file. So you insert the file. Then the pre-flaring file with quite brushing toward the outer wall to remove this dentine triangles that represent an interference during mechanical shaping. This way, you'll be having a straighter access to the apical portion of the canal. And here I'm speaking first about the safety. I know many of you or many clinicians that can skip many steps and go directly with mechanical preparation with rotary files, but here I'm speaking about safety, especially for beginners. We can combine both steps, inserting the hand file size 10, K file size 10, and the pre-flaring file using a file of small tip diameter and also small taper in pressureless way. Don't push. If the file is going easily in the canal, it's okay. Don't push the file. We insert the file passively. Also taking the file upward toward the outer wall or the area with dentine blockage. In brushing motion, quiet brushing motion, we can remove the coronal interference, so we'll be having a better access to the apically working file. This file is a new file, which is 13 tapers 3 AFF1. I will speak later about this file and the other sequence. But the main point is when to use file like this for preparation, coronal flaring, or even if you were taking it more deep during initial phase of preparation, take the file pressureless. Don't push the file inside the canal. I'll show you a case. We can notice in this case, we have a multiplanar curvature in buccal root of this maxillary molar. To reach to apex or the apical foramen using a hand file directly or even rotary files as some prefer, you might have some challenging. You might have errors. Ledge or perforation could happen, instrument separation could happen, even canal straightening could happen. That's why during the pre-flaring step, we need to remove this dentine triangle. After removing, for sure, we're removing this by brushing motion toward the outer wall. After removal, we have a more straighter access to the apex. We can have a safe way to the apex and avoid many errors that could happen during maintaining the shape of this canal. And this is the case after finishing obturation. For the pre-flaring steps in canal like the MP2, it is very important to know actually where is the orifice of the MP2. In this case, when you look at this the axis, we can see a red dot or a blood spot on the floor that represent the place or site of canal entrance. Sorry. So this is the initial catch by K file size 10. If you continue by this file epically in this site, you might have a stoppage. Most of dentists whom having a problem with MB2 telling, doctor, I can go 2 millimeter or 3 millimeter only inside MB2, then I found blockage. I can't progress more. Yes, the initial catch of MB2 most of the time is covered by dentin. We need to remove this dentin first to be able to reach the canal and have a straighter path to the apical foramen. We can compare here the actual site of the orifice and the point of initial catch. They are not the same. That's why it is very important if you are going into MB2 is to go passively, gently, don't push your instruments. This is the error that could happen during forcing instruments into MB2. Here, the doctor who referred the case told me, I found the orifice of MB2, I was happy. I start to do pre-flaring in this site to the canal, but suddenly I have a blockage. It's the first file, it was new, but he has a blockage. And we cannot hear the coronal curvature of the canal. We have dentin over this part of the file. We need to remove. We can remove using ultrasonics or something like Mons pairs. Gently under magnification, we can remove this part of dentin. This way, we'll be having a straighter access to the canal, and we can negotiate safely the remaining portions, the middle and the apical portion of the canal. So it's very important to stay passive if you are not sure if you have a bus in this area or not. After preparation of the coronal third and enlarged small third, we need to have a glide path. A glide path, according to John West, he defined a glide path as a smooth radicular tunnel from canal orifice to physiologic terminus to the apical foramen. We need to have a smooth path. To confirm we have a good glide path preparation, we need to have file 10 super loose. And again, here I'm speaking about safety to avoid errors. And I'll speak after a while about some advanced points that some clinicians like to skip. So once you have a super loose file 10 in the canal, it is safe to start to use rotary instrumentation or for mechanical root canal shaping. In some canals, we might be having already or existence of glide paths, maybe in palatal canals of maxillary molars or distal canals of lower molars, file 10 might go easily without any movement of the file or any scouting motion. The file is going easy. So already in these cases, I have a glide path. If I don't have glide path, I need to create it, or I need to go in the main path of the canal to have file 10 so loose. Going into the canal using file 10, we need to pre-curve the canal. I don't like to go by straight file inside the canal. Most of canals are curved, and I need the file, if there's a curvature, to follow the curvature. Don't push. We need to scout the file. We need to negotiate the canal. So we pre-curve the file. We can do the pre-curving using a tweezer or a tool like Endobender from Cypron Endo. Just pre-curve the file and start to negotiate and scout the canal. And the most used motion to negotiate the canal is a watch, wind, and pull motion. In this case, we're having two tight or narrow canals. I use the ADTA to facilitate the penetration of the file into the canal. This is a pre-curved file 10. And this is the motion. As you can see, it is very, very gentle motion. No force. Not pushing. If I'm having resistance, I'll not proceed with the file apically. I'll stop, take the file out, clean, irrigate, and re-enter the canal again. You have stoppage, take the file out, clean the file, irrigate, go again in the canal. You can go safely without any error. And this is a very important step. Having glide path is a very important step. especially in cases like this. This case took 1 hour from me to reach to the full length. And I don't worry, take one visit, 1 hour, no problem. Let it take what time. But any error happen before reaching to the full working length will double the complexity of the case. Suppose you are not able to reach the apex and you did a ledge or you separate an instrument. Now you need to deal with two complications. You need to manage the heterogenic errors that you did, either the ledge or separated instrument, and regain the original path of the canal, which you were not able to gain before the error. So the complexity will be much more difficult or will worsen the case. That's why take your time for the glide path, because any error before establishing glide path hardly corrected. But after glide path preparation, if any error happen, correction would be more easy. Those are some articles written by John West about glide path preparation and the importance of using manual glide path before insertion of rotary instrumentation. And I like the quote or the message he delivered in these articles. He was writing that like something like the canal is speaking to the dentist. How to safely shape this canal or how to safely prepare this canal. And the canal is saying to the dentist, you have never seen a canal like me before. I am full of curves and bobby traps. Treat me gracefully. Respect my delicate tissue and structure. And all you have to do is follow me to the end. Make me smooth and big enough for safe rotary, and you can have a way with me. Once cleaned, shaped, packed, I will reward you with a gift of healing. That's why no need for force during this step. It's very important to be gentle when applying or creating glide paths in very narrow canals. I know some clinicians like to skip this manual glide path and go directly for rotary instrumentation or rotary glide path preparation. According to literature, more than 90%, maybe 95%, also according to clinical practice, we can do that. But from my point of view, speaking about safety, and clinician can decide or can determine which canal he can go by manual file only, or we can go directly by rotary instrumentation. This is a nice webinar about mechanical glide path or manual-less glide path preparation done by Prof. Fabio Gori. It's already on Bob Dentistry website. I left you the QR code for the webinar. He's speaking about the mechanical glide path, going only by mechanical glide path. And yes, it's possible, and it is a repeatable procedure, but it is not about challenging myself. If I'm a clinician or a fresh graduate or new to the practice, please be patient. Don't challenge yourself to go directly by rotary instrumentation. Once you have a good training, once you develop your skills, I think more than 90–95% you can go directly by rotary. But here, choose a case and choose your files. In my opinion, and what I prefer to do is going first by using manual glide path file size 8 or 10K files, followed by the mechanical glide path, especially in cases with severe curvature. In cases like this, after I think it is hard or quite difficult for some to go directly using rotary files to establish glide path in these cases. That's why it is very important to go initially using hand files. One good point about manual glide path preparation is the tactile sensation. And dentist put his heart in his fingertips. I want to feel the canal. I want to feel if any blockage is there. I want to feel if any curvature is there. I can feel the canal. If the case will go smooth or I'll be having difficulties. This way I'll feel by manual files. With rotary file, we don't have the same experience or the same feeling. That's why in complex cases, I prefer to have a manual glide path followed by mechanical glide path preparation. After having glide path preparation or our file reach deeply in the canal, it is very important to inspect the file and see the file. Actually, the file, the small files, is taking impression to the canal. Yeah, radiograph is 2D, and we can't see buccal or linear curvature in this kind of radiograph. But if you have a look to the file, like in this case, if you in 2D radiograph, it's only a distal curvature. But look at the file, we can see a multiplanar curvature of the file. So it is not that easy. It is not one curvature that I need to manage. We have a multiplanar curvature in this case. So this case, difficulty level is high. So we need to plan our sequence. We need to select a good file that can maintain the original shape of the canal without causing any heterogenic error. During these steps also, we can explore the internal anatomy of the canal using the pre-curved files. Using pre-curved files and start to trying to negotiate the canal, trying to search for any anatomy. Sure, we're not doing this regularly in all cases, but sometimes you're going by your file, you find that it's still in place and going easily in another path that might be another canal. So you might need to pre-curve the file and going along the wall of the canal, trying to search or look for any catch. It might be another canal or another exit that needed to be cleaned. Glide path done, pre-flaring done. Now we want to take our instrument for the apical cleaning or for the apical shaping. Actually, crown down we are using for many years for safe root canal preparation. It provides a safer way for the instrument that going to work apically. Also, it is removing the debris in coronal direction. So we have less load of debris and dentine debris apically. So it would provide better cleaning. Also, it will allow for sufficient irrigation to reach to the apex to disinfect the root canal system. This is a way we were used to do crown down preparation. We prepare the coronal portion of the canal using flaring files. Then we go with less tapered file for preparation of the middle third or for body shaping. Then less tapered files we will take less tapered file to the full length to prepare the apical third of the canal. So each instrument is working only for 3 to 4 millimeter only on the first millimeter of the file. Not the whole file is locked in the canal, so we can avoid any fractures that could happen during instrumentation. Actually, the sequence or the technique I was using was profile rotary system maybe more than 11 or 12 years ago. I was using this sequence to prepare the canal. And after introduction of Pro Taper and the active cutting files, I started to hybridize my instrument, not to use one single system for root canal preparation, just to take the advantage of each system, especially for cases with severe curvature. Those instruments were shape memory files. It doesn't have sufficient flexibility to follow the severe curvature. That's why we might use long sequence. We might need to hybridize and use many instruments to distribute the stress on many files. So we'll be able to reach to the apex without any error. You can see here the cross section of Pro Taper or the active cutting files and the profile as a passive cutting files. The active cutting files have a high cutting efficiency. It actually cut in the canal. However, the passive cutting like profile, it do more scrapping action rather than actual cutting. So I'm using the active cutting file or this high cutting efficiency files for the initial phases of shaping, like pre-flaring, like body shaping, but I'm not taking this file to the apex, just not to have uneven reduction in the canal. At this step, I switched to a passive cutting instrument to be able to save the apical region safely. As I'm showing you in this case, this is the sequence I used in this case was multiplanar curvature. S1, S2 from pro-taper followed by a profile rotary system till the apex, so I was able to maintain the multiplanar curvature. Imagine continuing this case using only a high cutting efficiency files. Most of the time, I will be having a straightening to the canal and maybe perforation. That's why knowing the tool in your hand is very important. Another case, here also you can see severe curvatures, and this case is very special to me. I think most of you know why. Actually, I also hybridized my an instrument between pro-taper and the profile. S1, S2 as an active cutting files, as a file with good flare. It will prepare the coronal and middle portion of the canal, followed by a profile rotary system with less taper, just to follow the curvature and don't have that active cutting blades that might change the anatomy of the canal or might cause perforation or stripping to the canal. So we can maintain the canal geometry or the canal anatomy using these files. And believe me, now situation is more easy with the new files I'll speak about later. Companies start to develop the heat-treated nickel titanium to increase the resistance of the file to cyclic fatigue and torsional stress during working in the canal. And you can see many files are heat-treated in the market, but we need to know that not all heat-treated files are controlled memory. Not all heat-treated files are controlled memory. For sure, they are better than non-heat-treated files, shape memory files, in terms of cyclic fatigue and cyclic fatigue resistance and torsional stress resistance. But we have the controlled memory file, which show more flexibility than the non-controlled memory files. This is a difference between the austenitic or the shape memory files and controlled memory. We can notice here on the left that the file tend to regain its shape after bending. So when file like this work inside the canal, it tend to get straightened. So we might have uneven reduction inside the canal. We might have transportation to the apical foramen. You might have some zipping. Many errors could happen if you are not using this file properly. We use this file for a long time and still have good cases done by these files, but it is more dangerous that the controlled memory files that showing great flexibility and they can flow easily inside root canal curvature without tendency to straightening. So they will maintain the original canal anatomy with less incidence of errors. Many cases we use the heat-treated file or controlled memory file to manage severe curvature or multiplanar curvature. Already we know the sequence. Already we know that we need to pre-flare the canal. We need to have a manual glide path, mechanical glide path, then go apically with shaping files, less tapered file, 20, 25, maybe 30 if needed to prepare the canal. But why not to hybridize between the austenitic files and the martensitic, the files that have high cutting efficiency and the file which is flexible? In this case, I used the austenitic file to prepare the coronal portion and for the body shaping. These files that I used here have high cutting efficiency, but they won't follow to the end of the canal easily. That's why I switched to martensitic files, controlled memory files that can go easily and follow the curvature with less incidence of transportation. I think we have some questions. We can stop, take a break for questions. Okay, we have a question from Eugene. When we watch wind and pull, you continue to do that until you get resistance where the file doesn't advance. Exactly. When I'm using the file and go in watch wind motion, if the file can go easily with less force or less push, I will continue. Maybe 2 millimeter. I'm speaking about the narrow canals. Maybe 2 millimeter. I can remove the file and clean it. Then I irrigate. Then go again by the file with the file. But you can feel the resistance. If you feel it, it's better to go safe. It's better to remove your file and clean and re-irrigate. But if the file is going, maybe one shot I can reach to the apex. Another question I can see in the comments. Okay, when do you switch to a smaller file to negotiate to the apex? Usually I start by K file size 10. If I'm having resistance, I'm having difficulty, and I want to highlight a very important point here, the preoperative radiograph and the preoperative analysis to the case. From the preoperative radiograph, I can collect many data. If the case is difficult, is easy or easy. If it is difficult, I will consider using small files from the start. But if case easy, I will go using the file, K file number 10. If I'm having resistance or I'm feeling difficulty to reach to the apex, I might shift to a smaller sized file. No, with watch wind and the pull motion is a question. When you watch wind and pull, it is pressureless technique as well. It is gentle application or gentle introduction to the file to the apex or more epically. We need a gentle motion or gentle force. For sure, if I kept watch winding without pushing the file or trying to insert the file into the canal, I will not move or progress epically. But we can feel if you have resistance, I will not proceed. Or I will take my time doing this watch wind and pull and clean, watch wind and pull and clean. But if the file is going, I will continue. If it is not going, I might shift to smaller file to prepare the glide path. And in these cases, it is very important to take care, not to go fast, not to trying to proceed more epically, because many errors could happen during this stage or during these steps. I think no more question. Can proceed now. Okay. So
yes, sorry.
Okay, no problem.
With the microphone.
Okay. So this is a way I was doing shaping to this kind of cases is a hybridization between austenitic, martensitic, and in the past between active and passive cutting instruments. But today we have heat-treated files that all are martensitic, but with different properties. All are heat-treated, but with different properties. I'm introducing to you today the essential kit from Fanta, selected by Stella Italiano in Dontics. Actually, the kit composed of 4 rotary files, and we have already a size 10K file in the kit. But if we have a look to the system, we have a 13 tapers 3 file, which is very good file in negotiating and glide path preparation of narrow canals. We have a 20 taper 4, 25 taper 6, and 35 taper 4. And here I want to speak about very important point regarding this system is the optimized heat treatment or the hybrid heat treatment in system. Not all the files are with the same heat treatment quality or temperature. For a small file like 13 tapers 3, it is heat-treated file with some austenitic properties. The file is quite stiff. It is not that too flexible. And yes, this is needed for a file like that, because this file I needed to penetrate. I needed to progress. If it is a file that can be be easily blocked or stopped in the canal. I want to get the advantage of this file. That's why the file is a heat-treated file with some austenitic feature. I'll describe to you now in this video by Riccardo Tonini about the heat treatment. This file is a 13 taper 3. For initial phase of shaping, I need file with this quality to prepare the canal, who has some good cutting efficiency, and the flexibility of this file, the flexibility, it will be taken from the size. Actually, the size is small. So size is small, that would give the file good flexibility, and it is not that heat treated or not exposed to a high heat treatment, so it has some austenitic features, which is the stiffness. However, if you look to the 25 taper 6 is a file that will go epically, it has more flexibility. You can notice here the file can be easily bended and it won't gain its shape. So the file, yes, it has big taper, but it's flexible, because these files would most of time work epically, or I will take these files epically. Same for 3504 in large canal. So this is the system, 13 taper 3 for pre-flaring and a mechanical glide path file. The 20 taper 4 is for pre-flaring. I can use it for mechanical glide path also. And it could be a finishing file in very narrow canals. Many companies now are supplying size 20 file as a final shaping file. For sure, it depends on the case and selecting the master apical file. 25 taper 6 for pre-flaring. I can use it shorter of working length, the space or the length that 13 taper 3 go. I can use 25 taper 6 to pre-flare more the coronal portion of the canal, and it is considered also a finishing file in the regular canal. 3504 for sure, we can use it as a finishing file in large canals. The design of the files is a double S cross section with a flat design, and these features or this design provide more resistance to cyclic fatigue, more resistance to separation. It gives more room for debris removal and moving debris coronally. Also, it will provide center preparation to the canal because of the eccentric cross section of the file. And one good point about this kind of files is, if these files got separated for any reason in the canal, bypass would be easy, because we already have enough room to use the hand file and go beside the separated part of the file. So this is a very good advantage of the off-center cross-section or the flat design of the file. Also, we get the advantage of controlled memory files in two situations, and I think this is a smart application of controlled memory files in cases of ledge bypass and in patient with limited mouth opening. In case of ledge, after you bypass the ledge using manual file, if you try to insert the rotary file after the manual file, you might hit the ledge again. That's why you need to pre-curve or pre-bend your rotary file, insert it passively without activation, it's not rotating, passively till it passes the ledge, then insert your contra angle, start to rotate, then take the file up and down in short strokes, so you're diminishing the ledge and you prepare the canal beside the ledge. I'll show you now how we do this step. After manual file bypass, you just pre-curve the file, the rotary file, insert in the canal without handpiece on. Now I bypass the ledge using the pre-curved rotary file. Now I can fix my handpiece up and down in short strokes. Don't take it too much high, so you won't hit the ledge again. Up and down in short strokes. That way we are diminishing the ledge and we are preparing the canal beside the ledge, so we can safely reach to the apex or the full length. Also, for limited mouth opening patient, if you have a shape memory file and you have the handpiece and try to insert to molar side, you'll find difficulties in limited mouth opening patients. Sometimes we shift to shorter files to be able to do this step, but with controlled memory, the situation is different. we can pre-curve the file or pre-bend the rotary file while it is in the handpiece or the contra angle, go inside the pulp chamber. Now I can gain some length from the tooth itself or the pulp chamber itself. So the needed space in the patient mouth now is less. I'll show you now how we use the controlled memory file in limited mouth opening patient. As you can see, the file is pre-curved. I just insert the first few millimeter in the canal. Now the needed space over the tooth is much less. Now we can manage patient with limited mouth opening in better way. Up and down, up and down. Sometimes I prefer to use picking motion during preparation of the apical third or the apical portion of the canal. I'd like the picking motion. So brushing in first phases and the picking in the final phases of shaping. Same for the other canal. Pre-curve, insert the file. Now I gain more space. The needed space now is less to continue preparation to the canal. This way, we can get advantage of controlled memory files during root canal preparation. Now, I'm telling you the sequence that we need to know for root canal preparation using the essential kit from Fanta by Stelteriano selection. What is the sequence during preparation of narrow and difficult canals or regular canals? Excuse me, I think my battery is low. Just a second. Okay. So I'll tell you now the sequence that we need to know for managing narrow and difficult canals and regular canals, but we need to know that knowing only is half the answer. We will know what is the needed sequence, but believe me, the operator is the one who decides how to manage the case. Good training, developing skills, and developing the experience will let you will complete the answer, or implementing of your knowledge into your daily practice and having the good environment to a nice setup to shape the canal or implement your knowledge into your daily practice. Believe me, it will save you a lot. It will let you progress more, develop your skills, develop your experience, and for sure provide better treatment quality to your patients. So for regular canals, we can use 10K file and pre-flaring file, 13 taper 3 and 25 taper 6. This is short of working length sequence. The file is going pressureless without any pressure or too much of force. Now I'm preparing or already have a prepared or flared body of the canal, followed by a full glide path or full length sequence, taking my file, glide path file to the full working length, 10K file, the 13 taper 3, followed by 25 taper 6 as a finishing file. So this is an easy sequence for regular canal. But for difficult and narrow canal, we need to increase the sequence, and maybe in some cases we need to not too much enlarge the canal if we have difficulties like curvature or narrowness. In this case, as you can see, we use 10K file, 13 taper 3, 20 taper 4, 25 06 for coronal and body shaping of the canal, followed by complete glide path to full length manual, followed by rotary or mechanical glide path. Ending the preparation, we can end it using 20 taper 4%. For sure, we need to confirm that we have good cleaning. We can reach by our irrigant to full length or to apical portion of the canal to have the good disinfection. This is a risk and benefit equation. If you can increase the diameter of preparation or the size of preparation without risking your treatment or having possibility of an instrument fracture or any error, it would be good to stop at a smaller size and try to activate your irrigant, try to use many ways to take your irrigant epically without too much enlargement to the canal. For sure, as I said, it is a risk and benefit equation. Also for too or heavy curved canals like this, we can end the preparation using 20/4%. For wide and easy canal, it is a full length protocol. We can use size 10 and 13/3 of full length. Already we have a large canal, 20/4, 25/6. Sometimes we can skip 20/4 is canal is wide enough and end our preparation using 35/4 to the full length. So the essential kit is one system or different sequences for managing different difficulty level cases. Again, operator is a judge. Operator is the one who determines if I can take this file far epically or I need to prepare more chronally before taking the file more epically and expose my treatment to iatrogenic errors. I'll share with you this case with multiple difficulty. Actually, this case was referred to me because the dentist was not able to reach to the apex. He has difficult anatomy, curvatures, narrowness, ledges. All these errors or complication make the dentist who start to do the treatment not able to reach to the apex. So I started to manage this case. First, I choose my files that would continue treatment with me. Maybe I need to change the K file I'm using, going for stiffer files that can go through the calcification or the narrowness. In this case, I use the C-Flex file, which is stiff enough to continue or to negotiate or scout the canal without too much of distortion. We can see on from many clinicians photos of narrow canals that he used 10 or 15 small files. 10, I'm talking about the number, not the size. 10 or 15 K files for establishing the glide path. Maybe if you shift to quite stiffer files using with lubricant, you might be able to use this number of files. And files also should be flexible enough to maintain the canal curvature and to allow for safer glide path preparation. To reach full length in these 4 canals, it took from me 2 visits. No problem. 2 visits to reach to this length. Each session was about 1 hour, so it's 2 hours to reach to this full length. But after reaching to this to the apex or the apical forming, in this case, if any error happened, it should be easily corrected. But before, imagine I did a ledge because I was fast, because I need to finish the treatment in 1 visit, which I'm already doing in more than 97% of my cases. I'm finishing in 1 visit. But I'm not challenging the time. I'm not challenging my possibilities. If I'm having difficulties reaching to the apex and patient got exhausted, why to continue the same visit? Place a plain cotton, smooth the patient, and call another appointment. Take your time to establish or safely establish your glide path. It is very important. If any error happen now, suppose I have blockage, I have ledge, I need to manage my error only. I need to manage the ledge only because already the canal is there. But if I had a ledge before reaching to the apical foramen, I think it will be more difficult. I might spend more than 2 visits trying to solve the problem. After that, I continue treatment. Actually, because I was having a ledge which I bypassed by manual file. I use also the AFCL files, which is a reciprocating file, which comes already pre-curved. I'm using a reciprocation, so the file reciprocate inside the canal till he got the pass besides the ledge and continues the mechanical glide path also. I finished my preparation using 20/4, and already the canal was quite large or quite flared coronally. So I finished my apical preparation using 2506 AF-F1, and we can notice we safely maintain the original shape of the canal. We safely maintain the anatomy during preparation. This way, I think we come to the end of our presentation. Maybe now I can have some question, Nico? Yes. Okay.
I already sent them to you.
Yeah. Okay. I'll check now questions. Okay, how to decide master apical finishing file? This is a very important question. Deciding my master apical file, actually, I depend on the visual gauging. When I'm using the file to the apex, I need to see between the fluids of the file, the cutted dentine. If the file is already cutting, at the apex or at the apical portion of the canal, we will have, and I see dentine debris between the fluids. I think this could be the finishing file after delivering some good irrigant to the apex. But apical gauging, actually, I like to do with flexible hand files, night-tie hand files, corresponding to the size of the master apical file that I have did. Okay, another question. When we combine different mechanical file system, won't we have a problem after finishing with the preparation with the correct cone fit and the obturation? Okay, so we're speaking about the cone fit and the apical preparation. Actually, the cone fit, the point of cone fit, we don't mean to have the cone fit along the canal. We know the tug back. We know the true tug back. The getaperca should be fitting in the canal in the apical portion more than coronal. If the getaperca locked in the canal in the coronal in middle portion, you might be having spaces at the apical portion of the canal or in the middle portion of the canal, so you're not having a good obturation. Also, you might have an over obturation or pushing your getaperca or master cone beyond the apex. This is very important to select your master cone. There is also a very good and nice webinar for Fabio Gorni about how to select your master cone getaperca regardless the file system you are using. Okay. For ledge bypassing, you always use a manual file first to bypass the ledge, or have tried using an type pre-curved controlled memory file to bypass? Actually, my preference is to start by a pre-curved manual file. Pre-curved manual file. Sometimes, if I know that canal is already large and it is referred to me with a ledge, I can use a pre-curved rotary file like AFCL Blue, AFCL. It's a ledge correction file in a reciprocating motion. But I should know that the canal is going already. I'm having a path. If I don't have, it is better safe to use manual bypass first. Does it damage the handpiece when to attach the file? No, at all. If you attach the file to the handpiece inside patient mouse during the ledge bypass using rotary, it doesn't damage the handpiece. It's like you inserting outside the patient mouse. It doesn't matter. I have seen some clinicians start the handpiece once the file is attached to the handpiece, but not latched in. I think if it is latched, would be better. Not attached, it might get out also from the handpiece. The file may get out from the handpiece. Okay, after shaping curved canals, any tips for getaperca to reach full working length? Yes. Sometimes when you insert getaperca in severely curved canal, getaperca doesn't have the sufficient rigidity ability to follow the curvature. That's why we might need to shift our obturation technique maybe to a carrier-based obturation, where we have a solid core of gataperca or of a plastic carrier inside as a core, covered by gataperca, which is sensitive to heat. Use another device, or maybe a thermobrib oven like that. We put our carrier-based gataperca inside. I have the superficial gataperca hot or warm now. I can insert into the canal. I have a solid core, so I can push my gataperca reaching to the apex without any problem. Maybe also using of bioceramics in cases like this would be good, because of difficulty in inserting your plugger or heat carrier tip more deep into the canal. The 4 to 6 millimeters that we need to leave inside the canal at the apex, you might not be able to take your heat carrier very deep to reach this area. Okay, so we have another question: 6% taper or 4% taper for mesial canals of molars? To answer this question, I'll tell you the message that was in first slides in this presentation. I am a canal that you did not see like me before. Each case is unique. I cannot put a standard for a non-standard cases. I can't say I'll use 4% for this case, I'll use 6% for this case, or I'll do using 6% for all my mesial canals. Sometimes I am dealing with a patient like 13 to 14 years old with already wide canals in lower mesial molar. Why to use use only 4% files for preparation? I can use also 6% and it is safe. So it's case dependent. Don't try to put standards to non-standards. But most of cases, for sure, we can maybe you can prefer to use the 4%, not to over enlarge the canal. Okay, I can't see any more question. I don't know. Okay. Now we come to the end of our presentation. I think the presentation will be